able to attend in person or can only be on the call for a short period of time, you can access this webinar via the AFRI Health website. So for those of you that I have not met, good afternoon. My name is Mike Reed. I'm an infectious disease HIV physician based in San Francisco, and it's a pleasure to have all of you on the call today. Here in San Francisco, it's just turned 6:30 in the morning. It is a gloomy, cloudy day here. Recognize that some of you are at a different stage of your day, and I hope the weather is nicer wherever you are. Just a word or two about the etiquette for this webinar, as with others. I am going to take the liberty as the webinar host of placing everybody on mute, just to avoid noise pollution for other webinar attendees. And if you have a question, just add it to the chat box. And then I will try and answer it, or my co-presenter, Fred Sematala, can answer as well when he speaks. I'm going to take myself off of video now. Lovely to see you all. I'm still here. Get my picture rather than my video moving forward. We will begin now, and our goal is to go for 50 minutes and cover some important ground. Before I begin, for those of you that are in the midst of setting up your subcontracts and working with our program team in San Francisco, thank you so much. There is real enthusiasm here in San Francisco and excitement to be partnering with many of you in setting up these awards. So I appreciate that a lot of you are putting in long hours, and that's deeply appreciated, and will enable us to disperse funds to your institutions as quickly as possible so that we can get this project up and running. But this webinar is focused not on the program side of things, but really the core content for the webinar. For the Stripe module, and that's where I want to spend our time today. So in brief, the outline for today's webinar will involve a summary of the approach that we're adopting to undertake this teaching, something that was discussed in Lagos. And then my colleague, Dr. Sematala from Makerere, is going to talk about Module 3. And in the absence of Dr. Abigail Kazembe, who's out on leave to celebrate her son's wedding, I will talk briefly about Module 4 and PMTCT thereafter. So let me begin where I think we started last time around, which is just to review with you the approach to these to the Stripe modules. So the overall approach. The overall approach to these modules is that they will take place in small groups, and we anticipate that you will coordinate trainings such that they involve a diverse mix of health professional trainees, enable them to cover this content in groups between 4 and 8. We anticipate that learners should sit in a table, at a table together or sat in a group of chairs, and we would encourage learners to form groups so that different disciplines, nurses and doctors, are working together. And I want to talk a little bit about how facilitators can enable that approach, that small group approach to learning, to be effective. And then thereafter, I'll hand the speaking rights over to my colleague, Dr. Sematala, who will speak about HIV/TB co-infection module 3. All right. So let me talk a bit about the Stripe format. As I mentioned earlier, all the modules will essentially employ the same approach. So these are all case-based and use team-based learning. The idea is that this approach is learner-centered and teacher or facilitator-directed. A key question that has been raised is what kind of preparation do trainers, facilitators need in order to teach? Well, our conviction is that all of the trainers or facilitators need to have a strong grasp of the module content. But importantly, and I think this is something that really needs to be emphasized, we don't expect any of the trainers to undertake didactics or lectures as part of these modules. And this is a real strength of this approach. You know, for those of you that are nervous or anxious about standing up in front of large groups and leading a lecture, well, the good news is you won't need to do that if you're undertaking these modules or if there are members of your team that are undertaking these modules. However, I think it is important to appreciate the subtleties of small group teaching and the importance of being able to engage small groups effectively. And I wanted just to spend 3 slides talking about this. So briefly, tips for successful small group facilitation. And these are tips that you can share with your facilitators as you train them to use this resource. And the first tip is to organize the space. You will all have an idea of where you anticipate these trainings being undertaken. So, for example, it may be that it happens in a clinic waiting room which has been cleared out so that learners can gather, or it will happen in a classroom at the main teaching hospital. What we encourage is, regardless of the context, that in advance of the training, the room be rearranged to foster discussion and collaboration. And so rather than having desks lined towards the front, our hope would be to have chairs arranged in circles or around desks to facilitate better learning. The other thing, as I mentioned before, is to try and ensure that there is a mix of different professional cadres in each of the small groups. As I mentioned, our thought is to put 4 to 8 learners together in one small group. And you may have multiple small groups all attending the same module workshop. But try and make sure that there are pharmacists, doctors, nurses, social workers, laboratory scientists, all in the different groups. I recognize, based on our experience here at San Francisco, that many will resist this. They'll prefer to stay with people in their own cadre. And I think it's behooving on the facilitators to prevent this from happening. The other thing just to emphasize is the importance of setting expectations for the group. And so right at the start of the learning, we encourage your facilitators just to make the point that this is a safe space for learners, regardless of their stage in learning, regardless of their cadre, to ask questions and get things wrong. That's completely okay, and we want to encourage learners to feel comfortable in this learning environment. At this point, I want to draw your attention to a nice set of resources. There are a couple of tools that you can access online that cover some of this content very nicely, and I'm linking to them in the chat box now, that include YouTube videos that you can review at your leisure, that sort of underscore some of these issues in more detail. So if you or any of your facilitators are anxious about what it will involve to manage a small group discussion, then check out these resources in the chat box. So the second thing, and this is a really crucial element of the Stripe modules, is encouraging your facilitators, your trainers, to come prepared. I think only for a few master learners who are HIV experts with a lot of experience and educational expertise under their belts, should come without any preparation. It's our conviction that the facilitators should come having looked through, prepared the class materials, and be familiar with the facilitator's guide and how to navigate that. I think this is so important because it shows the students that you're really invested in them as individuals, and it highlights the enthusiasm of the facilitator for the material. I do recognize, though, that there's a heterogeneity of experience teaching this content. Some of you are not HIV experts, but you're nursing educators. Some of you are not content experts, but you understand how to do interprofessional education. And so for those of you, I would encourage you to use the background materials, the facilitator's guide, so that you come to the sessions with a clear understanding of the content, so that you can then teach it appropriately. This, I'm sure, is all intuitive to all of you in the room, but as you go back and train your teams to use this resource, I think emphasizing the importance of preparation is crucial. And to that end, recognizing you maybe have a 2-day Stripe fundamentals course with 2 days of different modules, you may well have to ask your facilitators to prepare several modules in advance, so that they come having looked through a number of modules and feel comfortable using all of that content. And that's not a small amount of work, and so the facilitators need to appreciate that. Key message here is that they can't just turn up on the day of the training and expect to be able to use the resources without having looked at them before. And finally, the final tip for excellent small group facilitation is the importance, but also the nuance around managing the discussion. As I said before, our hope is that the facilitators, the trainers, facilitate rather than lecture. And I think, having at your disposal, techniques for redirecting questions to enable the group to answer the issue at hand, rather than having the facilitator give the answer at the front is one thing to think through. I think it's also important to recognize that there may well be dominant students in the room, and I can imagine, at least based on my experience here in San Francisco, that those dominant students are likely to be men, and often likely to be medical students or doctors. And I think it's really important in this kind of environment where we're trying to foster an interprofessional approach to learning that the facilitators actively manage those more dominant students, redirect them, maybe even avoid engaging them, reiterate that the expectation of all is that there is team participation. And if a sort of a persistent dominant behavior happens, then maybe pulling that student aside at a break and just saying, look, let's give other learners an opportunity to engage. Similarly, though, I think there are probably members of the learning group that have a tendency to be quieter and say less. And again, I think in my mind there is probably a phenotype for who that is, and I wonder if it's the nursing student who doesn't feel as comfortable around medical students, who feels intimidated. I think it's important, again, right from the get-go, to say that those voices are important, that they need to be heard, and that you want to hear from them. In terms of encouraging those quieter folks to participate, I think one thing that can be done is encouraging, pair sharing. So just asking them to share their answer with a neighbor rather than with everybody. And then again, at a break time, taking those individuals aside and just saying, I want to hear your opinions. It's important that you contribute to this learning. So those are just some key messages that we think are important, for your facilitators as they undertake these learnings. Having said that, now I want to segue to the next section of this webinar, which is a review of Module 3, the assessment of HIV/TB co-infection. And I'm going to hand the microphone over to my colleague, Dr. Semitala from Makerere. And quickly, Fred, can I hear you?
Hi, Mike. Hi, everyone.
Great. Go for it, Fred. I'll let you lead.
Okay. Thank you, Mike, for setting the stage for this discussion and giving us those great tips on how we can facilitate this interprofessional learning. Greetings to everyone from Kampala. And I have several colleagues from Makerere who are joining from different places. Please excuse my voice. I'm just recovering from a cold, but I hope I'll be able to take us through. So this module, which is module 3, looks at management of HIV and TB co-infection. So the overall goal for this is to prepare learners to provide team-based care and follow up for a patient with HIV and TB. And we think that this module will exemplify the role, clarification and use of evidence-based medicine, and also with reference to country-specific guidelines. We know that some of the aspects might be different in the different countries, and so we believe that there will be room for consultation with the guidelines. Next slide. So based on the comments and feedback we got last week when the first 2 cases were presented, I thought it would be good to start with the case scenario that we based the discussion on. So our scenario is of a 32-year-old Michael, who is a shop attendant, and he has 3 children, aged 12, 10, and 8 years. He also shares the house with his 64-year-old grandmother, in addition to his family members. And he presented to the outpatient clinic with a 1 month's history of cough, which has not responded to 2 courses of over-the-counter antibiotics. He also notes that he has lost significant body weight. 2 days prior to visiting the clinician, he took an HIV test during a community HIV campaign that was happening in his area and was found to be HIV positive. And the community counselor advised him to visit the clinic for management of his HIV and also to follow up his cough and weight loss. So that is the case scenario that we use to set the stage for the discussions. Next slide. So with that, we have 7 objectives, and we think that by the end of the module, the learner will be able to, 1, describe a diagnostic approach to pulmonary TB in a patient recently diagnosed with HIV. The second objective is that they should be able to describe when and which ART or antiretroviral therapy regimen to start in a patient on TB therapy, and also identify the drug-to-drug interactions between HIV and TB medications. They should be able to describe how to counsel a patient on adverse events or side effects that are related to TB, and also suggest a follow-up plan for a patient with TB and HIV co-infection. Preferably that the patient will make similar visits, like for both TB and HIV, unless there are reasons why they should get the medications or the care separately. But we prefer that the treatment is integrated. Next slide. So number 5, they should be able to describe how to manage the transaminitis in a patient with TB and HIV. And we'll see, so in this, when we treat people with HIV and TB, we see a number of patients developing different levels of liver injury as an interaction between the 2 treatments. And so we want the trainees or the learners to be conversant and be able to manage these when they arise or if they arise. So number 6, they should recognize the importance and describe how to initiate a household contact evaluation plan for this patient as a quality improvement. because we think that if you are going to treat TB, you should be able to link the people who are likely to be infected, identify them quickly, and also put them under care. And number 7, to identify indications for and the options for TB preventive therapy. So those are the 7 objectives that we think the learners will be able to understand very well, or to meet during the study. So next slide, please. So this slide is it's a bit crowded, so you'll excuse us, but this shows what strategy we are going to use, and what evaluation we are going to use for the learners to make sure that they get they address the objectives that are set. So for the first objective, we think that we'll have a group discussion, and here we are, as Mike informed us, we are thinking that there will be 4 to 8 trainees in per group. And also we mentioned that we will be able to foster interaction and allow for the interprofessional interaction, so that each of the team members can be able to bring out their role and also be able to understand the role of other trainees. And the method of evaluation here, we will use pre and post MCQs. So these will be related to the case scenario and the subject matter. And we hope that by the end of the session, their performance or understanding of the question will have improved. For objective 2, we are going to use the same method, discussion, and we also think we will meet that by pre and post multiple choice questions. So to describe how to counsel a patient on side effects, toxicities, and suggesting a follow-up plan for the patient with TB-HIV co-infection, we think we'll have a writing exercise, and then we'll have a discussion. So we'll allow people to jot down what they think are the key counseling points for the patient related to the potential side effects that they could get while taking both TB and HIV medications, and trying to point out which anti-TB or ART medicines cause which side effects and how to look at them. And then here we think that we can also assess that in terms of evaluation, where we plan to use a pre and post, but also we can use a Likert scale, and people see if they agree or disagree, or how strongly they agree with a statement or disagree, to show that they have appreciated the process. Number 4, we will, as before, we will use discussion, and the facilitator will moderate the discussions around the psychosocial implications of TB, largely to look at TB-associated stigma and how that can influence treatment outcomes for the patient, but also how the learners can learn to avoid or minimize that kind of stigma, and what kind of things that they can engage the patient with to minimize or address the psychosocial issues that are related to TB. Issues like people being overtly concerned about infecting their family members, and that helps us to link them to TB preventive therapy. So those areas will, the facilitator will moderate the discussion around that. Number 5, where we are looking at at the managing the liver injury, which is potentially associated with some of the anti-TB meds. We'll again use the writing exercise as I've described, and eventually have a round table discussion after people have jotted down some notes. And then we'll use a pre and post or a Likert scale kind of evaluation. For number 6, the importance of household contacts. Hopefully that will come out earlier, but if it doesn't, we think that this will be managed by discussion to assess who is at risk, how do we get to test and what kind of test, and how do we exclude TB in them, and what kind of mechanism can we use to get to them. And the evaluation will also use a Likert scale. Number 7, we are looking at indications for the treatment options for TB prevention, preventive therapy. And so depending on what the guidelines recommend in the different countries, we hope that the facilitators will facilitate discussions around those different medicines, whether it's isoniazid or whether it's rifapentine and isoniazid, and how it can be accessed, how it can be taken, and any of the challenges that those bring, and how they can be prevented or minimized. So that is, so for the evaluation, we'll use a pre and post evaluation, some multiple choice questions. So that is the summary of that case discussion.
Thank you, Fred. That's very clear. I don't want to surprise you with extra questions, but I was hoping that we could just close out the summary of the case by just sort of re-emphasizing the answers to these key questions. So, to your mind, and you're the real expert in this core content. What are we trying to communicate here to the learners, Fred? What do you want all of the learners, regardless of their professional discipline, to walk away knowing after they've taken this case?
I think one of the things that we want the learners to take home is that there are complexities when someone comes in with both TB and HIV. I think it is now easier to diagnose diagnose HIV. But for example, the diagnosis of TB in HIV is complex. Some of the commonly available tests may miss the diagnosis of TB, and so the learners need to appreciate that. In addition to that, the other issue that they should clearly understand, and it comes up very regularly, is what do you prioritize to treat? Is it the TB or is it the HIV? And when you prioritize it, when should you bring in the other medicines? In this case, in all case scenarios, we want to start with the TB treatment. But when do you bring in the antiretroviral medicines? And how do you make sure that you can give both those medicines safely? So some of those look complex, but we can simplify them for the learners to appreciate why we do that and the evidence behind that. And of course, the other one, which is common, is we talked about the psychosocial issues around TB, HIV. I think that has to be appreciated, and learners appreciate how to deal with patients who have those comorbidities that are often stigmatized. And lastly is the issue of prevention and the quality issues around it. How do we make sure that the people who don't have TB are actually protected even while one of their close relatives has TB? How do we make sure that that happens and happens safely?
That's great. Thanks, Fred. Sort of as a follow-up question, and I think you have answered this in in the presentation you just gave, but what are the core things you think from an interprofessional education point of view in terms of tools that we're using here that are worth sort of underscoring, and how do you see this being taught in an interprofessional manner?
I think right from the beginning, as you mentioned, I think as a facilitator has to promote the appreciation of values and the ethics of working in an interprofessional group. And then within the team, people should be able to define their roles and responsibilities within the group, and be able to affirm their views and share their perspectives. Because as we know, for example, when you are, excuse me, when you are talking to a person who has TB and HIV, and you are trying to elicit issues of stigma, for example, that in most cases, in scenarios where there is a counselor or a nurse counselor, they tend to bring those out better than, say, a physician like myself. And so within this group, we would promote role definition and responsibilities, but also communicating, like allowing people, giving an opportunity for people to feel safe to communicate what they think. So basically using a patient-centered approach where each one of us is more concerned about contributing to the patient's well-being than about whether I'm a nurse or I'm a counselor or that. And then the teamwork, because we want them to recognize that we can only improve the quality of care if we work as a team, rather than each one of us working in our different silos.
That's great. Thanks, Fred. There's a question here from Hoffy. Should we be prepared for a question on a patient already on ART diagnosed with TB? Do you have any thoughts on that, Fred, and how we could respond to that?
I beg your pardon on the question?
Should we be prepared for a question on a patient already on ART diagnosed with TB?
Yes, yeah, we should be. I think the issue there is going to be maybe how they deal with the pill burdens, but likely the other issue is any potential toxicities that come up with, maybe something that we should, that even when you've not started a patient on treatment yourself, there are those issues that might bring a patient back to you who has been put on both treatments. Yeah, I think that's another important thing that we could put into consideration.
Certainly, I think that there's opportunity to revise and edit the module, and we could certainly we could include another question addressing that particular scenario, which is not uncommon. So thanks, Hoffy, for that. One last question for you, Fred. There are a number of additional resources in the packet that is included in the module, including guidance on hepatotoxicity management and side effects of the drugs. Can you give us an answer to a question about whether you expect the learners to learn this or just know where to go to find this information?
I think if time allows, especially like how do you deal with this liver injury and that, I think if time allows, it would be good for the learners to discuss that, but also to be showed where they can, to be able to go with one pager or something that they can look up to, what tests to do, what history to take. But I think discussing it as a group and they allow them a chance to share their experiences might provide a good opportunity to start the whole process of thinking about it in a more practical way than academic, yes.
Great. Well, thanks, Fred. That's really helpful. And I just want to sort of emphasize my gratitude for your willingness to work on this module. I think it's a really excellent well-crafted module, and it speaks to your expertise in this domain. So thank you for sharing. If I may, I'm going to move on now to talk about the next module, module 4, which is on prevention of mother-to-child transmission and the care of the pregnant woman with HIV. And I should add here that this is not my expertise. My colleague Abigail Kazembe from Malawi prepared this module and is unavailable today to speak on it. But in brief, the hope in this module is to prepare learners to manage care for pregnant women, new moms and newborns living with HIV, and underscore the importance of an integrated approach to service delivery that emphasizes the crucial role of different healthcare professionals in managing the mother-baby dyad in that critical early period of life. And so we hope that learners will recognize the risk of HIV acquisition, identify appropriate ART, identify strategies for preventing mother-to-child transmission. As I'll speak in a moment, the module pauses to reflect specifically on the importance of early infant diagnosis, and then the unique needs of mothers and newborns, a reflection on the importance of interprofessional team-based care, and ends with a focus on a quality improvement agenda. And I'll go through these things step by step. As Fred outlined, this case also includes a vignette that begins the module engagement and then tracks its course throughout the module. This case is a story of a 24-year-old woman, Ruth, who is pregnant, who actually tested HIV negative in the first trimester of her pregnancy, and then comes back in late in her third trimester and is HIV positive. From a public health point of view, this phenomena of HIV acquisition during pregnancy and or in the postpartum period is not uncommon, so it was something we thought was worth emphasizing. And this provides an opportunity to speak to the importance of prompt ART initiation for pregnant moms. In this particular scenario, she is not on ART at the time of delivery and has a detectable HIV viral load. Something we come back to in the course of the case. So in terms of the module roadmap, again, this is a sort of a busy slide, but I'll walk you through it and identify some of the activities that this module includes. So the first piece of the module involves a recognition of the risks of HIV acquisition during pregnancy and breastfeeding. And we hope that in small group discussions, the learners can grasp how there is an increased risk of HIV acquisition in the third trimester, and they can discuss perhaps some of the reasons why that is, and highlight the crucial importance of HIV screening throughout the pregnancy as a consequence. The second activity relates to objective 2, and this is about the appropriate ART options during pregnancy. This is really a hot button topic right now, as many of you will be familiar with, in terms of the potential risk of fetal abnormalities that were thought to be associated with dolutegravir. We now have late-breaking data that demonstrates that dolutegravir is not associated with an increased risk during pregnancy and remains probably the most effective treatment for many women, particularly because of its impact in rapidly reducing the HIV viral load. So we want to spend a moment talking about that and other ART drugs and their safety in pregnancy. And we think that talking about that in a small group context is a useful means of discussing that. The next and important activity in this module is to lead the trainees in a discussion of strategies to prevent mother-to-child transmission in a mother who's presenting late in pregnancy with a high HIV viral load. And this includes a discussion on the importance of ART prophylaxis for exposed infants. For many learners, this will be outside of their wheelhouse. They may not have had much teaching at all in this domain. And so what we hope is that the facilitator can use the complementary PowerPoint slide deck to help the learners, lead them through an algorithm that demonstrates when newborns are at highest risk for perinatal acquisition, and so I refer you to the slides that come with Module 4 for further review. In this same activity, we asked the learners, if the mother presented to care 4 weeks before going into labor, what would you recommend versus presenting right at the time of labor? And this, we think, is an opportunity to discuss the potential utility of dolutegravir for rapidly reducing viral load compared to other drugs. And then we offer another scenario to the learners. If the mother had come with a detectable viral load at the time of labor, what would you use then? And so this is an opportunity for the facilitator to lead the groups into a discussion on the importance of enhanced postnatal prophylaxis, or EPNP, for use in higher risk scenarios. And the role of dual ART therapy in the infant, so AZT and nevirapine as the WHO guidelines. This, in all fairness, this is quite dense stuff, and I think facilitators need to really know this going into the case. But it's really important that not just physicians, but also nurses and pharmacists understand this, because it's so crucial to quality of care for the mom-baby dyad that everybody understands these nuances. So activity 4, it provides an opportunity to discuss the importance of early infant diagnosis. And this in itself can be complicated, because how do you diagnose HIV in the infant, given that there are many maternal antibodies that end up passing to the infant in breast milk and in the peripartum period? And so, you know, the learners should understand why we use a PCR-based test to detect HIV at this stage, but more importantly, recognize that EID is really crucial, because the first 2 months of life, or rather the first 3 months of life, are when most HIV mortality happens in infants with HIV. And so EID, early infant diagnosis, is critical to early initiation of life-saving ART treatment. In babies diagnosed with HIV, in addition to using WHO or country-specific guidelines, it may be necessary to also consider the mom's ART regimen. And so, having having these issues discussed in a small group format, I think it will be useful. Activity 5 is an opportunity for learners of different cadres to really think through what are the unique needs of mothers and newborns related to HIV. And so we want to ask the groups to consider, have you ever cared for a mom with HIV who's just delivered a baby? What are the issues that you encountered? What are the potential barriers that you have to consider in terms of stigma and discrimination? And again, I think this provides an opportunity to really think of the mom-baby dyad, not just through a biomedical lens, but really in the bigger psychosocial context, in terms of stigma, discrimination, disclosure to the spouse and family members, the importance of adjusting to a new chronic illness. And actually, I think in this kind of situation, often doctors have a lot to learn from nursing colleagues. Activity 6 relates to objective 6 around leveraging quality improvement to address a key area of service delivery for mom baby dyads with HIV, and I'll spend a moment talking about that. Key questions: what are the learning methods that we're using? So I think, our hope is to sort of focus primarily on small group learning. There is an opportunity to engage with some data and critically evaluate a few pieces of data that are included in the supplementary resources for learners. And the core content that we're trying to emphasize here is, look, the risk of HIV acquisition of women of childbearing age and the importance of screening for HIV during pregnancy to prevent mother-to-child transmission is a key learning. The importance of understanding essential mother-to-child transmission interventions and the role of an interprofessional approach to mitigating the risk of mother-to-child transmission. And then thirdly, the importance of improving quality of care for the mother-child dyad, especially with respect to early infant diagnosis. So those are the core contents that we're addressing. In terms of the essential IPE tools, I think the format and interprofessional format, the thinking things through a full sort of psychosocial biomedical lens at the same time is key to thinking about, how we teach this in an effective team-based methodology. And then the last question is, what are the QI methods? And I skirted over this very briefly. For those of you that weren't on last week's webinar, a key thing that we want to tease out of almost every module is the opportunity to improve the quality of care for individuals living with HIV and at risk for HIV. And in this particular vignette, we focus on the opportunity to improve early infant diagnosis. Many of you will have encountered that scenario in your clinical practice where a newborn gets tested for HIV and the result goes astray, or the result is not available. And so we use that as an opportunity to think through, how could that be prevented? What are the opportunities for a clinic that's delivering care to improve low EID rates? And so you imagine if you're in charge of a clinic and you have very low early infant diagnosis rates, how could you address that? And so we propose using the Ishikawa or fishbone diagram. So look, I don't want to sort of go into too much detail on this now. This approach to quality improvement has been around since the 1920s. It was developed by the manufacturing industry in Japan. And I think this was first used in the Kawasaki building plants to improve the quality of their manufacturing projects. And it's a framework for thinking through what are all the things that could go wrong, or what are all the things that explain variability in quality of an outcome. And so here we're thinking about, in the setting of low early infant diagnosis rates, what are the possible explanations for that? And we really just want learners to kind of think this through. How can we think through the different aspects of service delivery that could impact upon low early infant diagnosis rates? So here, if I advance the slide, I think you'll see, in the facilitator's guide, we give some examples, but our hope is that the small groups will come up with some of these themselves. And so as an example of some of the things, so we highlight people, environment, materials, methods, equipment. If it's people, does the test not get done because the doctor's writing is illegible? I know that happens. My writing is pretty lousy. Maybe the lab tech is overwhelmed and unable to track the result. Maybe the escort service isn't there, or the phlebotomist doesn't do the test. And these are just illustrative examples, but I think they, you know, it's a way for the learners to try and understand that the many different ways that can impact quality of care in this particular vignette. Our hope is that this just becomes a resource that they can then use and take into their broader clinical practice through other problems, other issues of poor quality. So I think that's it. Let me just advance the slides. Yeah, so those are the main things on this particular module that I wanted to address. There's a question from Hajida. What important points to emphasize according to scenario during pregnancy, labor, and delivery, Agatha and Tanzania? So I think that the important things that we want to emphasize here along that sort of care continuum for pregnant moms is all of the potential opportunities to screen and identify HIV as promptly as possible and to initiate mums onto ART as soon as possible, and we use the WHO algorithm to highlight that. So if I just advance the slide, I think it's here at the end. Bear with me a second. Not there. I thought it was in there. I was going to share with you a slide that sort of illustrates the WHO algorithm and the utility of that as a tool for highlighting where in the care continuum for pregnant moms one has to focus in order to prevent mother-to-child transmission. So now another question here is who sets the pre and post training MCQs or LICOT? Great question. Thank you for that. And apologies that wasn't clear. So the expert panel and UCSF have provided a set or will provide a set of MCQs that can be deployed at before and after the training. Our vision is that if you're undertaking a 2-day workshop, there would be 4 compulsory modules, and the MCQs from those 4 compulsory modules are undertaken by all learners across sites, across institutions, and therefore we're able to compare apples to apples. You know, we can see, you know, how folks are doing in different settings because we have that core set of MCQs that they'll take pre and post. At your individual institution, beyond those compulsory modules, you can then pick and choose what modules you take. And UCSF and the expert panel have developed MCQs that you can then use. And those MCQs will be on the website and will be available, you know, to complement each module. So if you choose module 4, there are 3 MCQs that your learners can take before and after taking that module. They, just so you know, sort of the process that this goes through, the expert panelists came up with MCQs. They have been peer reviewed by folks here at UCSF, and now they're being peer reviewed again by a cohort of experts from across AfriHealth. So those questions are appropriate to the learners that you're in front of, and hopefully are things that not only demonstrate change in their knowledge, but also are you know, are reasonable given that their professional status and cadre. And similarly, LICOT scales are being being addressed. I see a question here. WHO now recommends a minimum of 8 antenatal contacts rather than 4. Please send that feedback through. We will include that. You know, I'm definitely happy to update all of these modules responsive to the most up-to-date guidelines. And so if 8 is the recommendation, then we should include that rather than 4. As I said at the beginning, this is not my wheelhouse, but I'm happy to edit as appropriate. And then somebody from the Nigeria team has suggested that this module provides an opportunity to discuss the issues around the window period. I think that's a great comment, and we can think about how we can address the challenges of acute HIV seroconversion and how you detect HIV at that time. So I think you know, we're at the end of the hour. Just close out. If you have any edits or revisions on any of the modules, 3 or 4, please send them to stripehiv@ucsf.edu by August 23rd, and they can get incorporated into draft 2.0 that we will send to you early in September. So we want all of your comments and feedback as soon as possible. So thanks for that. And then let me just remind you that these webinars are going to continue on a weekly basis until we've covered all of the content. So we anticipate 10 weeks of webinars. So week 3 is August 27th, and we'll be looking at module 5, the care of the adolescent, and module 6, post-exposure prophylaxis. If you have any other questions, then feel free to email me or the Stripe HIV email address. Let me pause, and if there are questions, I'm happy to entertain them now as well. Okay, I'm going to close now and thank my colleague Fred Sematala from Makerere from Kampala for joining me. As I said at the beginning, couldn't be more grateful for Fred's input on these modules, and in her absence, Abigail Kazembe from Malawi, you know, who led on these 2 modules. I look forward to seeing you all bright and early my time, not your time, next Wednesday, same time, same place. So thanks for your time, and I look forward to seeing you all then.